Hello again. So I'm going to focus on hyponatremia. Even though it says other electrolyte disorders, I don't think there's enough time in 15 minutes to cover all the electrolytes. But happy to take questions about other electrolytes later. I'm going to talk about perioperative hyponatremia. Bottom line is, if it's not in your comfort zone, get someone involved whose comfort zone it is in. Don't hesitate to call a nephrologist. But if this is managed by hospitalists in your institution, call them as well. And the earlier you get someone involved who is comfortable with hyponatremia, the better the patient's going to do. Hyponatremia is common. This is an old slide on the left, and if any of you are doing inpatient work, you're probably seeing a lot more hyponatremia than you did in the past. We're going to be looking at our own institution because I think any time I'm on consult service, I'm seeing 5 hyponatremic patients. It's sort of like it's out of control. I don't know exactly why. I think we've got sicker, older patients on drugs that induce it, but the numbers are high. You can see that the total number, if it's mild hyponatremia, less than 136, but even less than 116, we're seeing it both on the admission side and then also on the hospital acquired. And really what I'm going to speak today is more about the hospital acquired, so sort of post-operative. It's important, obviously, to recognize preoperative hyponatremia, and if it's present, at least think about what's going on if you're doing the pre-ops. And don't start them on a thiazide diuretic if their blood pressure is high, because you're just going to make it worse. Seems to be the most common issue. Just to point out, mortality goes up as hyponatremia goes up, and actually on the hypernatremic side, we see increased mortality as well. I think a lot of folks ignore the hypernatremia. Like, oh, sodium is 143. If any of us in this room had a sodium right now of 143, we'd probably be outside drinking out of the toilet bowl. We'd be so thirsty. So take hyponatremia quite seriously. It's a strong predictor of mortality as well. So what is the concern with hyponatremia? So initially, when it's acute, you get water flowing in the brain and the brain expands. And so what you're probably going to see more in a post-surgical patient is an acute hyponatremia, hypotonic fluids, ADH levels high. Patient starts to complain of headaches, sodium's going down. Do not send them home until you've made sure it's going back up again. And that's the acute component. But as the hyponatremia persists, the brain is able to adapt. It starts kicking out, it lowers its osmolarity so that the water then flows back out and you don't have the brain edema. Now you've got a chronic hyponatremia state. And the bigger problem there is as you recorrect the patient that you don't do it too fast. And so we've got these problems on both ends that you might need to deal with in a post-operative patient. Now, how's this all happening? I think the bottom line here is when you drink too much water, you pee the water out. Drink too little water, your kidney's going to hold on to water. How does that all happen? Well, we have hypothalamic osmoreceptors in the brain, and what these do is if my osmolarity goes up, my kidney's going to want to hold on to water to dilute it down. If I drink tons of water, my osmolarity goes down. I'm going to have very light colored urine because I'm going to get rid of the fluid. And that's all done through ADH. ADH, antidiuretic hormone, vasopressin, another name, holds on to water in the kidney as a response to this osmotic change. However, there is a second way, and this is when you start to get in trouble because this will win. Every time, volume always wins, right? In evolution, I think it's an evolutionary thing. As we get hypotensive, we turn on ADH just to hold on to water because volume matters. I don't care what my sodium's going to do, I'm going to hold on to water. And why that's relevant? Because my heart failure patients have turned on ADH because it's saying, you know, my volume's low. It's not really, but my brain thinks it is. I'm going to hold on to water. Liver failure patients do the same thing. My volume depleted patients will do the same thing. ADH levels go up, I hold on to water, and I could get hyponatremic despite the fact that maybe it's not really the primary problem. So what's going on at the kidney level? Not to give anyone PTSD from med school days, but remember that we have this countercurrent mechanism. And I'm now going to go through every step of the countercurrent. No, I'm just kidding. I still can't figure it out. I just know it happens. But basically what happens is once your sort of primordial urine gets to this point of the nephron, if you do nothing, it's going to be very dilute. And so if I have a dilute state, I don't turn on ADH and I pee out this very dilute urine. My urine osm should be less than 100. The corollary is if my urine osm is greater than 100, it implies that there has to be ADH circulating. unless some old people sit around 150, but certainly it's greater than 100 in a person who's otherwise healthy, there is ADH. And then you have to think, should that ADH be there based on what their serum sodium is? If not, that's inappropriate secretion. And the opposite happens when I have a patient who has excess sodium in the blood or excess sodium concentration. I'm going to turn on my ADH and I'm going to hold on to water. Now remember, I'm also going to turn it on if I have excess volume, and in that case, my sodium concentration doesn't really matter. The point being, ADH around urine osm more than 100, not more than serum osm, which is what a lot of people think when you have something like SIADH. Not going to go through the whole algorithm because I only get 15 minutes here, but there are things you need to do, and generally in the post-op patient, we're not going to suddenly have someone who's got pseudo-hyponatremia, unless you're giving like massive doses of like IVIG or something. It's generally not going to be the case. We do want to make sure they're generally hypotonic, and ultimately, once we've gone down this path, we make sure someone's not getting excessive fluid, they're not drinking too much. We do have patients who, when you're not looking, are drinking tons and tons of fluid, and they'll have a low urine osm. Those are just my sort of polydipsic patients, psychogenic polydipsia. There are other causes of polydipsia. But ultimately, we're probably in a post-op patient going to be dealing with this group of patients, either a low volume, where water is sort of given, but they don't have solute, or my patient who's got normal volume, euvolemic, and they have SIADH. And that's probably going to be the most common cause of hyponatremia. It's inappropriate ADH. Why is it inappropriate? Because I have a low sodium in my blood, but my urine osm's high, so there's ADH around. It shouldn't be around. I should be peeing out dilated urine. ADH is being stimulated by non-osmotic means. Okay, in this case, volume. In this case, my brain's just churning it out for no good reason, or at least we don't know what the reason is. And then we also have these volume overloaded patients, and so you may be seeing heart failure or cirrhotic patients, maybe patients going in for their transplants. A lot of hyponatremia there, and we'll talk about that in a minute. These guys all look the same on the labs. You really have to examine the patient. I'll see my fellows doing the computer biopsy, and they're like, oh, I think the patient got SIADH. And I say, have you seen the patient yet? And you can't tell the difference because they all look the same chemically, except SIADH will generally have a high urine sodium. Now, don't get confused if there's a low urine sodium, because the urine sodium is managed by my renin-angiotensin-aldosterone system, and my urine osm is through ADH. And these things act independently. So I can have an SIADH patient who then gets volume depleted and the urine sodium drops. So low urine sodium doesn't rule out SIADH. A high urine sodium probably rules out volume depletion, except if you're on diuretics, which a lot of our patients are. So again, you've got to examine the patient and look at all the factors. So here's a patient, 65-year-old man, recurrent diverticulitis. He gets a resection with a temporary loop ileostomy, and post-operative day 1 is doing reasonably well, and then gets nausea, pain, vomiting, and then over the subsequent days, that serum sodium just starts to kind of drop slowly. And hopefully you've picked it up here, but we'll sometimes get called with a sodium of 124. Now, this isn't hyperacute. Certainly, if it went from 135 to 124 overnight, which we sometimes see, that'd be extremely concerning, because next time it's going to be 115 and the patient's brain's going to expand a little too much. So what do we do? So when you're seeing a patient with post-op hyponatremia, it's usually excess ADH release. Do we call SIADH? You can, but it's excess ADH release. Why is that? Stress, pain, nausea. These are all stimulants for ADH release. And so you try and control each of those independently. And with time, they will come under control and this will correct. But in the meantime, you may need to act if the sodium gets too low. There are a number of medications, your SSRIs, your antipsychotic meds. A lot of folks are on these meds coming into surgery, may have a baseline sodium of 134, which no one recognized because, 134, it's not a big deal, right? Most of us don't even notice that, but it's where they start. Volume depletion could be superimposed, and then infection. So anything in the lung could obviously cause also SIADH or ADH release. In post-surgical patients, there could be excessive hypotonic fluid administration, half normal saline, or other hypotonic fluids. And just keep in mind, there is another entity that looks very similar in its numbers. Like if you look at the urinosm, serumosm, those things, they look the same. It's cerebral salt wasting. The difference is these folks get very rapidly volume depleted. They're all polyuric. So if there's no polyuria, it's probably not cerebral salt wasting. They also have very high urine sodiums. But just keep in mind, you see someone who's suddenly making tons of urine and the sodium starting to drop. Those people could be in extreme danger if you don't get them in an ICU and get saline into them. You shouldn't see it too often. If you take care of post-neurosurgical patients, that's probably the population where this happens most often. So what do we worry about? We worry about cerebral edema, and if someone's sodium's dropping quickly, correct it quickly. No risk in doing that. Osmotic demyelination, if the sodium has been low for a while and you correct it too fast, usually by more than 8 to 10 a day, you can get osmotic demyelination and severe neurologic problems as a result of that. I will say that there's recent literature that says this isn't as big a deal as we used to think it is. I don't want you to believe what you're reading about, oh, it's not a big deal, don't worry about it. It does happen. There are folks out there who are trying to say that rate of correction doesn't matter. I truly believe that they are wrong, and the way they've interpreted the new data is incorrect. But where they are correct is if the sodium's starting above 120, you're highly unlikely to osmotic demyelination. So you've got a little bit more leeway when you start recorrecting. If it went up by 11 or 12, leave it. But certainly when you have very low sodiums, that's the problem. Osmotic demyelination usually happens 1 to 7 days after the overcorrection, and the MRI may be delayed, so you have to go by the clinical features, and they may all sorts of really nasty neurologic deficits, swallowing issues, problems getting this locked-in syndrome is rare, but it could happen. But just be wary, someone who had a low sodium and now they're not acting right, they could have osmotic demyelination. The MRI may not be helpful right away. Now, who's at risk? These folks, the sodium below 110, that's who I'm really going to worry about. Almost every case we see in the literature is this group. It can happen at 120 to 120 range. I'm still very cautious, but this is the patient who's going to get it. If they drink, if their potassium's low, it's going to make it worse. Liver patients, for some reason, do worse. Malnourished patients do worse. They probably do worse with everything, right? It's probably not unique. And then older patients on thiazide diuretics, probably because when you stop the thiazide diuretic, they suddenly reverse themselves too fast. Not because of the thiazide itself, but because someone says, oh, you're hyponatremic, I'm going to stop your thiazide, and then things just fix themselves, and that can happen really fast. So how do we treat this? The first question we have to ask, does the patient have symptoms? How long has it been present? And is the patient at risk of developing neurologic complications? The symptoms are non-specific, really mental status change, certainly when you're really low. And usually you don't see these symptoms unless it happened really fast. We have patients walking around at 105 and they walked in the ER by themselves because they felt a little off. So non-specific symptoms, you're going to check the labs. If it's severe or acute, you're going to use hypertonic saline. I would put them in an ICU, and really for all these scenarios, just call a nephrologist if you're not comfortable doing this yourself. It does require very tight management. Not that people can't do it, but if it's not something you're used to doing, just get someone who's used to doing it. If it's mild to moderate, you can really just restrict fluids. If you've got your patient who's post-op and they went to 124 like the patient we saw, just restrict fluids, they'll probably be okay. And then you treat volume depletion if it exists. Keep in mind, if that's what's driving things, they'll overcorrect because you've now turned off the ADH secretion. There are some rules. Some have said increase by 6 as fast as you want and then just keep it there. Sometimes easier said than done. And then you just stop at that level. If it goes up by 8, I think most people feel that it's probably safe as well. But aim for 6. Don't go more than 8 in a 24-hour period. It can be in the first 6 hours and then stop. And if you overcorrect, give water back. There are different strategies. One is if you overcorrect, you give D5W. And this 3 milliliter per kilogram will bring the sodium down by about 1. And you can use desmopressin. I think the theme on this is that desmopressin is really, really helpful. If your patient overshoots, you've got to give desmopressin so that you can counteract that that overshooting, and you're basically giving them ADH back so that they stop overcorrecting and you can concentrate their urine again. The ideal approach is probably this one, where you're sort of watching it closely and you give something before they get to a point where you have to rescue them, where it's much harder to do that. Again, you're going to involve specialists in this area. So we've got this patient. Is he symptomatic? No. If yes, I would do 3% saline. If it's acute or chronic, in this case, it's acute. You could probably correct him as quick as you want. If he's symptomatic, just give 3% saline, get him up fast. Is he at risk of osmotic demyelination? Probably low risk. This didn't happen too fast, but it's not that low. And then the management in this case, I would do fluid restriction, give fluids if they're hypovolemic, and stop hypotonic fluids. So just one last slide. I think that there is one group of patients where I do worry a little bit, and those are my patients going in for a liver or heart transplant. They preoperatively hyponatremic. I would really try to get their sodium up to like 128 to 130 before you send them in the OR. Sometimes I'll get a consult the morning of the heart transplant and the sodium's 120. And they go, hey, can you help us out with this? And I'm like, okay, how are you going to keep that sodium from going to 135 when you're replacing half their blood volume? Very challenging. We do sometimes use intraoperative dialysis to try and keep it down, to help with that. And as I said before, limit that correction. So I'm over time. I'll stop there. Happy to take any questions during the question and answer session.